Hello there. My name's Gavin Britton. I'm one of the medical doctors. I've been asked today to have a look at the nerves in your face, if that's all right. Is it Mrs. Edwards?
It is.
Well, I'd like to start with just a question, and then I'm going to go on to look at your eyesight and your vision. Have you noticed any change in your sense of smell?
No.
No. I'm going to have a look at your vision now. So if you can cover one eye up for me, and if you can read from the top down.
TVHXUAHTYOVUAXTHAYOUX. That's as far as I can go.
If you swap eyes for me.
TVH. That's it, I'm afraid.
Okay, thank you. I'm going to have a look in the backs of your eyes now, yeah, so if you could pop your glasses off for me. I'd like you to just look at the wall behind me. I'm going to come slightly close to you and have a look in the backs of your eyes. But you just blink as normal. If you can look at the light for me. That's fine. Have a look in the other eye. If you look at the light. Okay. So I'm just going to have a look at your eyes now. If you keep looking over my shoulder, I'm just going to shine a light into your eyes. Okay, thank you. So if you can look into my eyes, and then I want you to point to which hand moves.
That one. That one. Both. Both.
Okay, brilliant. And if you cover up one eye for me, I'm going to cover up the same eye, and I'd like you to tell me if you can see the red pin.
Yes. 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 Yes.
Okay, I'm just going to bring it in from the side. Tell me when it comes into your vision. Keep looking into my eye.
Yes.
Okay.
Yes.
Okay, I'm going to swap hands. You stay as you are.
Yes. Yes.
Okay, swap eyes for me. And again in the middle. Tell me.
Yes. 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 Yes.
Okay, and just out to the side. If you tell me when it comes into your vision.
Yes.
Okay.
Yes.
Okay. And swap eyes.
Yes. Yes.
Brilliant. Okay, thank you. If you can look at the wall behind me, and then look at the tip of my finger. That's fine. And then what I'd like you to do is if you can keep your head looking towards me, and with your eyes if you follow the tip of my finger. Let me know if you get any double vision.
Jumping.
Oh, okay.
Jumping. Jumping. Jumping.
Just up here.
Jumping.
And then down to the bottom.
Jumping.
Okay, thank you.
Sorry.
It's okay, take your time. I'm going to have a look at your face now and how your face muscles are working. So if you can clench your teeth for me, just going to have a feel of the muscles. Okay, thank you, and relax. I'm going to tap this onto your jaw now. What I want you to do is if you just relax your jaw for me. That's okay. And if you open your mouth and don't let me close it. Okay, that's fine. It's just a bit of cotton wool. I'll show you what it feels like on your chest bone. Can you feel that?
Yes.
I'm going to touch it on a couple of places in your head if that's okay. Can you feel that?
Yes. 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 Yes.
Okay. Does it feel the same on both sides?
It does.
And does it feel the same as in the middle?
Yes.
Brilliant. Okay. I'm going to have a look at some of the muscles in your face now. So if you could lift your eyebrows up for me. Screw your eyes up really tight and don't let me open them. Okay. Open your eyes for me and smile. And if give us a yeah, that's fine. That's okay. I'm going to have a look at your hearing now. So I'm going to cover one ear and then make a noise in the other ear. If you can tell me if you can hear it.
Yes. Yes.
Okay. I'm going to have a look at your mouth now, if that's all right. If you could pop your mouth open for me. I'll just have a look at the back if you can say ah.
Ah.
That's okay. Can you stick your tongue out
1
for
minute
me?
remaining.
And waggle it from side to side. Okay. And if you stick your tongue into the side of your mouth, and don't let me push it. And the other side, again, don't let me push it. That's okay. And then I'm going to have a look at your muscles in your neck now. So if you lift your shoulders up for me, don't let me push them down. If you can turn your head to one side for me, don't let me push it over. And turn your head to the other side. Don't let me push it over. That's fine. And relax for me. And then I want you to repeat a couple of phrases for me. So, baby hippopotamus.
Baby hippopotamus.
And 42 West Register Street.
42 West Register Street.
Okay, thank you very much. That's everything for today. To complete my examination, I'd like to check this patient's corneal reflex, gag reflex, and perform an examination of their upper and lower limbs, and check this patient's gait.
Thank you. Could you present the case to me, please?
So this lady has evidence of a cerebellar ataxia. My findings on examination were a head tremor, truncal ataxia, nystagmus in all directions of gaze, as well as she complained of a jumpy vision or oscillopsia. She also had scanning dysarthria evident throughout the examination. As an aside, there was evidence of reduced visual acuity in the right eye. However, there wasn't any evidence of a relative afferent pupillary defect, and fundoscopy was normal, so I don't think the optic nerve is affected here. My causes for this lady's cerebellar ataxia, I could split these into acute and chronic causes. My acute causes would be primarily vascular, be that hemorrhage or more commonly infarction. However, I'd expect infarction to be unilateral rather than this examination being suggestive of bilateral. Other causes of acute cerebellar syndrome would be cereballitis, so infections such as varicella, or autoimmune causes. And I'd also be looking at demyelination as a cause of acute syndromes like this. My chronic causes would be split into primarily alcohol as the most common cause. There would also be nutritional deficiencies, as well as genetic conditions, surgery and previous trauma, and other infections as well. To investigate this lady, if this was an acute cause, I'd want to do a CT of this lady's head to look for any bleeding or infarction, and if this was a chronic cause, I'd primarily want an MRI of the brain.
Okay, thanks. You've diagnosed a lady with cerebellar ataxia and said you'd want to go on and do a full neuro exam. What signs might you expect to see on limb exam in this case?
So on further examination of this lady, I'd be expecting to see an intention tremor and pass pointing. I'd also be looking for other features of incoordination, such as dysdiadochokinesis and heel shin ataxia. I'd also be looking at a gait, and I'd be looking for a broad-based gait.
Okay. When doing the full neuro exam and assessing the limbs, are there any other signs that might be helpful in working out what's going on with this lady?
So I'd want to be screening for other associated neurological features that might indicate for instance, spina cerebellar syndrome or a peripheral neuropathy in combination with the cerebellar syndrome. So for instance, I'd be looking, in terms of the spina cerebellar features, I'd be looking for upper motor features such as upgoing plantars and increased reflexes. I'd also want to look at the peripheral nerves to look for any evidence of peripheral neuropathy in combination with the cerebellar features that might be suggestive of, for example, alcohol.
Okay, let's return to the history. What are the key areas you'd want to explore when assessing a patient who presents with cerebellar ataxia?
So primarily I'd want to firstly establish the onset and any progression of the cerebellar ataxia. I'd then want to go on to screen for other associated neurological signs and symptoms that might be suggestive of certain conditions, such as multiple sclerosis. There might be an element of relapsing remitting to her disease process. And I'd want to screen for other signs and symptoms that might be consistent with things like alcohol as well. I'd then want to go on to screen for evidence of systemic disease or nutritional deficiencies, and I'd specifically want to be making sure that I'd ruled out malignancy as a cause in terms of paraneoplastic syndrome. I'd then want to go on to check this patient's relevant medications and previous medications, as well as drugs and alcohol as a cause. Lastly, I'd want to check the patient's family history.
Okay, thanks very much.
Thank you.
This candidate presented a case with signs of cerebellar ataxia on cranial nerve examination. The neurologic examination was performed in a confident, fluent and well-structured manner. All the key elements were covered, and the potentially tricky bits of the exam, such as eye movements and visual fields, were well performed. There were some aspects of this patient assessment I really liked. When fields were assessed, the candidate checked for an obvious field defect and visual neglect before assessing each eye's field in more detail with a red hat pin. Whilst it's possible to check fields with just your fingers, the pin does allow for a more sensitive examination, and the central field areas can be better assessed. You can check for enlarged blind spots with a red pin, but it's not routinely required and is only really relevant when the history and/or other signs suggest raised intracranial pressure. Don't worry about spending a bit of time on these components of the cranial nerve exam. The lower cranial nerves can all be checked very quickly. When performing the neurological examination, it's really important to give clear instructions to the patient, and the candidate did a very good job in this case. In addition, listen carefully to what the patient is telling you during the examination. In this case, the patient complained of a slightly unusual problem. Her vision was jumping during the eye movement testing. Don't just listen to what the patient is saying, listen for how it is said. In this case, you can hear the dysarthria. The signs here were relatively subtle, with nystagmus in all directions of gaze and staccato speech being the most apparent abnormalities. The patient described visual disturbance in the form of oscillopsia. Other useful observations include the presence of head tremor and the presence of truncal ataxia. These findings are extremely useful as they clearly point towards cerebellar pathology. Having identified these cerebellar signs, the good candidate will know what limb signs to be on the lookout for. In a case like this one, we might expect to see intention tremor with dysmetria, dysdiadochokinesia and gait ataxia. Even though you might be able to predict other cerebellar signs, the limb examination is going to be very important. The signs we've seen so far clearly suggest cerebellar disease, but it's useful to know whether other components of the nervous system are implicated. This might give clues to the etiology of the condition. For instance, the combination of cerebellar signs and upper motor neuron signs in just the legs would be clear evidence of lesions disseminated in space and might, in the context of an appropriate history, support a diagnosis of MS. Conversely, the finding of peripheral neuropathy signs, in conjunction with the cerebellar findings, might make you consider toxic causes such as alcohol. One final thought on cerebellar ataxia. The cause is usually evident from the history, and clearly the cadence of onset is critical. Investigations will be guided by the history, but all patients with cerebellar ataxia will require brain imaging. MRI is far superior to CT for looking at this area, but CT has an important role to play in hyperacute presentations when hemorrhage needs to be rapidly excluded.